have obtained a healthcare clinic license as required in Florida statute, or that you have a certificate of exemption. So this is not a new requirement in Florida law. Any entity that is rendering healthcare services and seeking reimbursement from a third-party payer like Medicaid or Medicare is required to have a healthcare clinic license. We are just simply making sure that all of the group agencies and providers actually have obtained one. So we will begin that verification process later in the year. On the slide, you see a link to the agency's website. That link will take you to where you can learn more about the healthcare clinic license if you are not currently licensed and need to obtain the license to meet the requirement. It has the information about the application, the cost of the application, and so again, hopefully all of you are already licensed, and this is a no-brainer. You're just going to be submitting that verification to the agency. But if you are not, we are giving you information on where you can go to our website to obtain any information in that regard. Again, this is not a new requirement. The healthcare clinic licensure law passed in 2003. And so it is the provider's responsibility to self-report to the agency, to our Division of Health Quality Assurance, if they believe that they meet the healthcare clinic licensure requirements. And so we do rely on the providers to do so. We're just validating and verifying that you are in compliance. So we have received a lot of feedback about our current service authorization process. And so we are planning on implementing some improvements or enhancements in that process. We intend on deploying a multidisciplinary team approach in the authorization of behavior analysis services. The multidisciplinary team approach, we believe, will be the most beneficial in determining the appropriate services and supports that children with disabilities and delays who are seeking behavior analysis services need to help us ensure appropriate and comprehensive care planning. The MDT approach will have three components. There will be a telephonic or face-to-face discussion with the parent. Most of the discussions will happen over the phone, but if there's a need to do one face-to-face, it will be through a home visit. So the parent will not be inconvenienced in any way in having to travel to an alternative site. We have found this to be a very helpful tool when we are reviewing services for children with very complex and involved needs. We implemented a similar approach in the approval of private duty nursing services, and it worked wonderfully. We have service coordinators that go out to the parent's home or remain engaged with that parent telephonically to gather more information that is used in the prior authorization process. So that is the first step. We will also have a medical documentation review conducted by clinicians from two separate disciplines. So oftentimes the clinical or behavioral issues that are presented in the request may be treated in a number of ways. And so we are going to deploy a multidisciplinary team approach to reviewing the information that is submitted as a part of the prior authorization process to make sure we are approving the most appropriate services in meeting that child's need. So that may be that it's approving behavioral health services and recommending that other services and supports be supplemented and be complementary to the behavior analysis services. It may also mean that there are times when it's determined that another intervention or modality is tried before behavior analysis if the intensity of the child's needs are lesser and other treatments or interventions may be equally effective. But the goal at the end of the day is to make sure that all of the needs of that child are met. So that is our primary and chief goal. If it means authorizing additional services, then that is what we will do. And then the last part is a team meeting. And so not every single case will have a team meeting, but many of them will. And we will invite the parent and the child, if old enough, to participate in that team meeting. The providers will also be invited to the team meeting as an optional participant. We certainly want the provider there, but we recognize that you're seeing clients and patients all day long. The team meetings will be done mostly telephonic, so we're going to reduce the travel of having to go to alternate sites. There will be times where a team meeting is face-to-face though. Again, it will be optional if the provider wishes to participate. The provider will have the opportunity to submit as much information as necessary to make a proper decision through EQ Health, as EQ Health will be responsible for the multidisciplinary team approach. They will submit the same documentation that you submit now, the behavior plan, the assessment, et cetera, et cetera. So EQ Health should have all of the information needed from the provider, but we certainly welcome your participation in the meeting if you're a provider here in the audience. We will also invite the child's physician and any other treating practitioner involved in that child's care who wishes to participate in this opportunity. The multidisciplinary team approach will help to ensure that children are receiving the most appropriate and comprehensive service package, as I've said before. Children will continue to receive all medically necessary services. We believe that this approach will help us receive information from a multitude of sources that will help us make the best decision for that child. We anticipate that the multidisciplinary team approach will begin in July of 2019. However, we have asked EQ Health to begin contacting parents as early as May to begin those discussions and those parent interviews that I spoke of earlier. So parents, and so we issued a letter to parents a couple weeks ago letting them know in anticipation of those phone calls being made. Okay, so we are on coverage policy changes. So we are going to be doing a couple things with the behavior analysis coverage policy. We will be combining it with other Medicaid covered behavior modification and intervention services so that we can show the continuum of services that are available for children with maladaptive behaviors. The services that will be included in the combined coverage policy include behavioral health day services and therapeutic behavioral on-site services, or TBOS, as most of you may know it to be. We will also clarify the provider's supervision and documentation requirements, and we will also strengthen the requirements, holding true to the principles and rigor of applied behavior analysis supported by evidence-based practices and principles. So we have heard from you in this regard also, a desire to have more guidance and clarity from the agency in the coverage policy. My team has been reviewing a ton of material to make sure that the documentation requirements that we include in the policy are sound and based on evidence-based practice, and the requirements that will go into the policy are supported as such as well. As you know, any changes that occur in our coverage policies go through the full rulemaking process. So you will have ample opportunities to provide comment and feedback and review the changes throughout the rulemaking process. We will have rule workshops, rule hearings, in addition to presenting the information that I'm sharing today all throughout the state. So please know that there will be opportunities to review and provide comments. The next change is implementation of electronic visit verification. So we have been engaging in requiring electronic visit electronic visit verification for home health services for a number of years. I think as early as 2011 maybe. So it is a long-standing practice, and what it requires is the provider to check in at the time when the service starts and check out when the service ends. I think almost all of us have cell phones, right? So the vendor that we will contract with will have a free application that you can download to your phone. So there will be no extra charges for the application. It will be enabled with GPS technology that will be able to pinpoint the location of the provider, and you will check in using the app and check out. It should not take more than a few seconds. It should not be disruptive to the care that you are delivering, but it helps us to ensure that on that behavior plan, to the extent that, or not to the extent, I know it's listed, the days and times that the services are rendered, that children are actually getting the care as prescribed on the behavior plan. Electronic visit verification is a very useful tool in ensuring that there are not missed visits, that children are actually getting the length of care and treatment that is prescribed on the treatment plan or care plan. It is really a useful tool in enhancing the quality of care that Medicaid recipients or individuals, consumers are receiving. It is a tool that is not only used in Medicaid, but through commercial payers, etc. So there will be lots of training that will occur to help educate our providers on how electronic visit verification works. And what it does is when you do that check-in and check-out, it matches against the service authorization information that is in EQ Health System, and then a claim is generated. And so that claim is generated within the vendor system and is transmitted to our fiscal agent. So there are a number of checks and balances that are embedded in the system to not only make sure children are receiving the services as prescribed, but that we are paying for services that are actually delivered. Okay, so next we want to talk to you about the reimbursement rates. So we will be realigning the provider reimbursement rates using information that was not available when the rates were initially established. Most of the original assumptions that were used to develop the rates have not held true. When we were initially designing this service, we intended for it to be for children with the most severe and significant behaviors. And as such, we thought that we needed to have rates that were aligned with that thinking. The data shows that the children who are receiving the service have behavioral challenges that range from moderate to severe. We thought that it would be very challenging to recruit a provider network to deal with children of such intense and acute needs. And so the rates were set at the level that it's at now, at a significantly higher level than we think is necessary to ensure access to services statewide, especially when we do research and look at the wages that are paid here in the state. We believe that the revised rates are commensurate with the practitioner's education, training, and skill level. We will ensure payments are consistent with efficiency, economy, and quality of care. The rates align more closely with the rates that are paid by the Agency for Persons with Disability, who covers applied behavior analysis under the iBudget waiver. They also align more closely with similar behavioral health services that are covered and reduce incentives that may be inherent in the system for providers to seek coverage of services through the VA benefit as opposed to more appropriate services that can equally and effectively meet the child's needs. We have a revised methodology that we are using for determining the rates, and it really looks at the wages that are paid using U.S. Department of Labor data, using wages that we saw from information on job search engines. It factors in administrative expenses, including rent, malpractice insurance, equipment, travel, and supplies. And then it factors in our utilization data. Here are the proposed rates. As I have stated before, for all of you who are taking pictures, the rates will be posted on our on our website later today. You will be able to download them from our website later today. Okay, so there is a slight reduction for the assessment. If I may ask that you allow me to finish the presentation and take your seats, that would be very helpful. Thank you. The rates for the assessment and the reassessment are slightly reduced. The rate for the lead analyst remains the same. We recognize that the lead analyst is directing the care, is developing the plan of care, and so there is no change in the rate for the lead analyst. The rate for the behavior analysis assistant is slightly reduced, and then the group rate and the rate for the behavior technician is modified as well. Again, we believe that these rates are commensurate with education, training, skill level, and is consistent with the average wages, even when you factor in reasonable administrative costs. As with any fee schedule changes, we will go through the public rulemaking process as well. These are not effective now. We have to go through a rule workshop, a provider hearing, etc. You will have an opportunity to provide feedback and comments on the rates. There will be an opportunity for us to walk you through the methodology. And if you believe that we have missed information in developing the rates, if there are other factors that we should consider, if some of our inputs are not accurate, you will have an opportunity to let us know that. And we will take that information into consideration as we progress through the rulemaking process. Okay, so we will have a very transparent process as we proceed. So as I previously stated, and as said earlier, we will have statewide public meetings all throughout the month of April into the early part of May. We will have rule workshops and rule hearings that you will be able to participate in and provide feedback. As a part of today's meeting, there'll be a question and answer session, but there will be an opportunity to have individualized topical meetings on each of these changes. So for the electronic visit verification, there will be web-based trainings that our vendor will host where you'll be able to get more information on that. For the rates and the coverage policy changes, again, there will be rule workshops that are specifically focused on those changes where you'll be able to provide comments and feedback. I know we published in our provider alert the potential or anticipated dates for future meetings around the state. For your convenience, it is included in the slide deck. And as you can see, we will be visiting Tampa, Orlando, Jacksonville, Miami, Fort Lauderdale, and Pensacola. We also will be updating our behavior analysis services webpage on the agency's website. We will put all of the information related to these changes on our website. We also will have a dedicated email address for comments and questions. The email address is on the slide. If you are not able to attend one of our public meetings, or you just have questions or comments that you would like to submit to the agency, you are more than welcome to use the the email address on this slide. Okay, so we are at that point where we are ready for public comment and questions. So this is how this is going to work. We have a speaker sign-in sheet that we had at the front when you signed in. We are going to allot a couple minutes. We have several speakers, so you can keep your comments to no more than a minute or two. That would be really helpful. We will go in the order in which individuals signed up. If you have your comment card and you would like for us to read it, if you want to raise your hand, someone can come and grab it, and I'm more than happy to read your comment or question and we'll provide an answer. Or if you did not sign up and you wish to ask a question or provide a comment, raise your hand after I go through the individuals who have signed up previously. When it's your turn to come up and speak, if you will come up to the podium and speak into the microphone, that will be helpful. And so I'm going to turn this like this a little bit so you can face our panel and the audience. So we will begin with Colin Straitman with Full Spectrum. Sure. The next speaker will be Andrew Tavares with FABA. Did I say that right? Okay, and then after that it will be Josh Pritchard.
Madam Secretary, we appreciate you showing up. Thank you, Beth Kidder, for what you're doing to protect the children and the finances of the state. Dennis, we appreciate and understand you're in a difficult position with EQ. Thank you for working to make sure the right stuff gets approved. I would like to just take a minute and educate you guys on some stuff that I feel like hasn't been brought to the surface. So in the state of Florida, costs have exploded for this treatment. We understand that, and that is not fair to the state. It's taking money from other programs that it should not take money from. Now, the reason it is exploding is because our field of behavior analysis, in most states, you have to be a behavior analyst to provide behavior analysis services. If we go just north to Georgia, they pay $107 an hour to BCBAs, but they don't let any of these other professions practice. You cross the state lines, now you're in Florida, LMHCs, LCSWs, LMFTs, other non-certified providers are calling what they do behavior analysis, even though by definition they're not behavior analysts. There is one certification board in the world that certifies behavior analysts, the Behavior Analysis Certification Board. 42% of your lead analysts are not BCBAs. So a parent basically has a 50-50 shot of actually getting a behavior analyst to show up to their house to help their kid. 4 out of 10 times it's going to be some mental health counselor who specializes in talk therapy. ABA is a science. I have Dr. Sarah Dillon, Dr. Terry Blackman, there's Dr. Josh Pritchard. This room is filled with doctors, with clinicians, with experts, with people that treat autism as a science, that take this as a passion, that we actually want to help these children change lives. I'm sorry for any LMHCs here, but y'all are a dime or a dozen. They're all over the place, and people do not use mental health counseling like they used to. So LMHCs are coming into our field to try to get work, because you can pay them $25 an hour and they'll work. So the reason when you're looking at these rates and you're like, how's an RBT making $90,000 a year in Miami? Because these Miami jokers are hiring a bunch of LMHCs to do the lead analyst role, and they're making $40,000 or $50,000 off the LMHC, because you don't have to pay these people nearly what you have to pay a BCBA, and they don't have to make any money on the RBT. Because in many cases, an RBT approved with Medicaid is more valuable than an LMHC. Now, my agency, we don't use anybody that's not a BCBA. Less than 1% of all of our lead analysts out of 200 people are not board certified behavior analysts. That's not the case with any of these agencies out here. And I've learned that now. I've been fighting this fight literally for 2 weeks, and I've already got 2 senators. A bill is approved in the House. It's already passed. It's going in front of the Senate. And we're going to get an amendment that's going to eliminate chapters 490 and 491 from being able to practice behavior analysis. If that passes next week, please don't cut rates. What's going to happen is all of us BCBAs that know what we're doing, we're going to go right up to Georgia. We're going to go to Valdosta, we're going to go to Atlanta, and we're going to make $160,000 to $200,000 a year. Why? Because we are in high demand. It is extraordinarily difficult to become a BCBA. It is not as difficult to be an LMHC, LCSW, marriage and family therapists. Come on, these people should not be calling themselves behavior analysts, and our state is doing a disservice to these children and to the families by allowing these individuals to continue to parade around like they're scientists.
Okay, Mr. Straitman.
Yes, ma'am.
I'm sorry. We do have a long list of speakers.
I'll end it there. Thank you for your time. I appreciate your attention.
Thank you.
to the committee. I'm Andrew Hoover, President of the Florida Association for Behavior Analysis. In the coverage policy revision, you stated at the bottom at your last point, to clarify provider supervision and documentation requirements for the Florida Association for Behavior Analysis. Stand by the notion that these behavior analysts that should supervise behavior analysts and behavior analysts alone. It's akin to your child's pediatrician showing up and trying to provide you anesthesia prior to surgery. You wouldn't accept it. We want better, and ultimately we want quality services for the children and adults with disabilities that most of us have spent a lifetime serving. Thank you.
Thank you, Mr. Kuvaris. I got it at that time. Mr. Pritchard is up, and then next is Karen Wagner. After that, Mary Gordon.
Beth, I heard that we have shared goals of best care, provider qualifications, poor service quality, elimination, reduction, and open dialogue. I think we all share that. And I want to talk about several points that I think hit all of that. I'm really excited to hear that we're getting a more robust clarification on provider supervision. I urge AHCA to also clarify qualifications of BA providers. There are 28 states that license this profession, and that licensure in each and every one is based on the board certification, the ACB qualifications. So that would be a good place to start, and it would help with making sure that insurance children get best quality services. I'm concerned about the rates proposed up here. The reduction of RBTs, I'm a provider agency, they wouldn't cover my wages of my RBTs, much less the requisite supervision that my BCBAs need to provide the quality of service. So when we're looking at just wages as the cost of service, there are a lot of bundled costs as well to provide good service and provide good prognosis for the children. So I urge you to invite providers to provide financial analysis of how we decide. I can tell you exactly what my cost of services is and use that versus a job search, because there are providers that are underpaying because they don't provide the quality, and so they don't need to invest the time. And finally, I'm curious, I'm hoping that we'll get some clarity, what the number of consumers of the private duty nursing that you're kind of basing the multidisciplinary treatment team, is that equivalent? Because I'm a little concerned that if we put in place those kinds of approaches, we might be creating barriers and delays to access. So when doing that, I hope that was examined. We certainly want to make sure that our parents aren't blocked from service by virtue of not being able to attend meetings. So I really appreciate your service to the children, and I think we have shared goals.
Thank you, Mr. Pritchard. If I can just address your last point, I want to clarify absolutely our intent and our goal is not for the MDT process to serve as a barrier. We will proceed with authorizing or reviewing the case even if the parent is not available or the provider is not available, and we will make as many accommodations as necessary to include the parent and include the provider, and do it at a location and time that is mutually agreeable. Okay, so that is certainly not the intent.
My name is Dr. Karen Wagner. I have a company in Brevard County called Behavior Services of Brevard. So I agree with many of the statements made by Josh and Andrew Hoover as far as making sure that people are qualified. There are provisions in the field of psychology for people to become qualified to do applied behavior analysis. The American Association of Professional Psychologists has a process. I believe the APA has a process. So it's not that it doesn't exist. It's just the problem we have is that the licensed practitioners of the healing arts, most do not have applied behavior analysis in their coursework. I know this because I'm a BCBAD. I'm also a licensed mental health counselor. I'm fully credentialed in both. I didn't get one because I had the other. And the differences between the two fields are enormous. The entire theoretical constructs are very, very different. So and there are right now 3,800 behavior analysts. In the state, there are 1,800 lead analysts. People qualify as a lead analyst, as a behavior analyst, but there are 45,000 licensed practitioners of the healing arts who have the ability to kind of self-identify if they are qualified to do the service. there are a number of people who are licensed who are attempting to get certification, they're taking coursework, and we applaud that. Obviously there are tons of kids who need services, but we want to make sure that the applied behavior analysis is applied behavior analysis. Another thing, a lot of the fraud occurred because companies came in who intended to create companies to do fraud. So it's not, there's kind of this little slap every time to behavior analyst, every time fraud is mentioned, but most providers of behavior analysis, we're trying to provide behavior analysis. It isn't our intention to do fraud, but there were companies, just like other fields, people came in with the intent to build the system, and so we want to just try to remind people that, this is not us. The Medicaid process, when the handbook was started in 2011, I actually met with Dee Dee Pickle and Melissa Edelman, and those initial discussions, it was always that the book was going to be open to people not only with autism, but also children in child welfare, because those individuals are greatly underrepresented, and so it was not really intended to be like really, really severe behaviors. However, I am a provider of people who have really severe behaviors, and the rates, those are based on behavior assistance, not RBTs. I was an APD provider for many, many years. Those rates are not realistic unless you're planning on having behavior analysts do indirect time. Because everything is hinged on the behavior analyst, the lead analyst, but we can't bill for their time. If they're writing programs or whatever, the rates for assessments and behavior plans, it takes days to do assessments, to do everything that's needed to update behavior plans. We're not compensated for that. So we're kind of forced into a loss leader position with that. But then when you're also going to say, oh, we have to do that, you're going to lower the rates, and then you're going to also still have the same demands on the behavior analyst, how are we supposed to pay the behavior analyst when you're not even reducing rates to behavior assistants or RBTs, which would not be right, since most of them went through this credential. So anyway, so there are some real issues there.
Thank you, Ms. Wagner. You mentioned the requirements that I believe should be in place for the other LMHCs or LCSWs that are providing the service. If you wouldn't mind sharing with us what you believe those standards should be. Not right now, but
yeah, I'm providing written feedback, so
okay.
I can certainly do that, but yes.
Okay, thank you.
Thank you.
All right, next up is Mary Reardon, and then we have Baker Wright, and after Baker Wright, we have Dr. Ashley Peter. We do only have about 10 minutes left. I know we started about 3 or 4 minutes late, so if you could keep your comments brief.
I'll try and be really quick. So I'm Mary Reardon with Florida Association for Behavior Analysis. I am really glad to hear that you're going to try and increase and change some of these processes so that these services will be available to these kids who need them desperately. I would really support many of the things said about increasing the qualifications. But a couple things I didn't hear you say, so that, one thing that our members are very concerned about is the provider enrollment. I mean, I heard some changes, but I didn't hear anything said that it's going to be more efficient for providers, so that when you have a well-qualified provider, that now they actually are going to be able to be approved as a provider. I didn't hear anything said about that, so I'm hoping that that's going to be a piece of this, because we hear all the time about providers who are well-qualified and serving in other funding streams but cannot be approved through the Medicaid system, so we're hoping you look at that. With the rates, I think we would love to work with you on this, because you compare it to APD rates and that kind of thing. That it's not comparable, because there are things that are billable under the APD system that are not billable under the Medicaid program, because indirect services and those kinds of things, the assessment rate that is not bundled as part of, in APD, we don't do, and we do a separate assessment, and then we have hours, we can do billable services that are indirect, we can bill for that. So I think looking at those things, looking at concurrent billing, which is not allowable under APD, and that would help cover the supervision and those other costs. So we would love to work with you and do some cost studies on that, because a number of our members do billing in many insurance providers and other kinds of funding streams. So we'd like to work with you on that. So thank you.
Thank you for that feedback, and I will say, I want to address the enrollment piece. When the rates were initially designed, we did bundle a lot of those indirect costs into the rates, and so if we need to revisit the construct, we're certainly not interested in doing so.
And I won't get deep into the provider enrollment issues. I mean, you all feel the pain. I feel the pain. A lot of you all contact me directly about the issues that you're having. So I know that we have a lot of work to do to streamline provider enrollment, to bring the processing times down. We have already implemented one reform that you're seeing with site visits, where you can now just FaceTime with our staff to do the final documentation pieces that you need, where we need to verify identity. So those are the things that we're trying to do. There are some concrete steps that we're taking. These changes will not happen overnight, but we are trying to have some things in place immediately for lifting the moratorium, the partial lift of the moratorium that we're talking about. So it is a major initiative for us to do this, not just for VA providers, but for all providers, and to do better customer service as well. So we definitely hear you on that, and that is something that is one of my primary initiatives for the next couple of months.
After Baker is Dr. Ashley Pierre, and then we have Suzanne Sewell and Chris Shaw. Chris, no.
Just want to thank you all for the opportunity to do this and to reiterate my support. I'm a provider. I also have a provider group that serves families and individuals across the entire state. And I think Dr. Pritchard and Dr. Wagner and Dr. Reardon spoke much of what our concerns are, so I won't reiterate those, but I will say that we obviously do agree with the agency in our hopes and desires to create a better quality across behavior analysis services. And I think that for us, it's important to increase the quality of services to maintain the quality of the provider. And I reiterate the notion that behavior analysis should be provided by behavior analysts and those who are registered through the BACB. And I think that creates a goal or reaches the goal of quality. Unfortunately, with the rate reductions, there is a conflict that as we increase the quality of the providers and at the same time reduce rates, those things will be in conflict with each other. And so if the hope for the agency is what I believe it is, which is to increase the quality of providers and quality of services, I would suggest that behavior analysts, those who are registered through the VACB, are the ones that are providing those services, and that there is some recognition of what's driving those rates, and that there is a potential for quality to go down as those who are highly qualified will find reimbursement very difficult. One question in addition to that, as it relates to your algorithm or your methodology in determining those rates, is that methodology, is that algorithm going to be, is that going to be available to us as we go through this process? I think that will be helpful because I believe that, as Dr. Pritchard said, if we keep it within behavior analysis, those rates don't make sense. I understand the methodology where you include a lot of other providers and how that will drive the rates down. But if we're trying to increase quality, we'll do so through quality behavior analysis providers.
Thank you. Yes, we will make our methodology transparent as we commence into the rulemaking process on the fee schedule. Okay, Dr. Ashley Pierre. Again, we are running out of time, so if you would keep your comments to less than a minute, that'd be great.
Let's try. All right. Good morning. I don't remember exactly the name, but he said that a problem well stated is half solved, right? What about when a problem is not well identified? We will never get to the solution, okay? First and foremost, Medicaid or AHCA get involved with behavior analysis services. It's been 6 years ago. Behavior analysis services have been going on for over 20 years, actually. And the kids with parents, with disaffected parents, were not having access to these services because they couldn't afford it, and Medicaid was not paying for the services. And then they had to post tests and a lot of situations and go to the court, and finally Medicaid was mandated to pay for the services. Now, we understand that you had to adjust to a new situation and then open up the services without even knowing what are the services. And everyone was doing it like crazy. And we get into the fraud problem. Fraud was the problem. And what we're managing here is not the solution to the fraud problem. Because a lot of RBTs, non-RBTs, anyone could have opened a data provider from the last 2 years. Anyone. Parents are providers. People are providers. And then they get the money. And then they pay the RBT or anyone else $30, $35, and just get the rest of the money in their pocket. This is what was going on in Miami and Broward County. So if you want to fix the problem, we need to adjust it properly. Okay? You talk about when you decided to have this rate, but 3 years ago, you had not the proper information. I agree. Because the problem is not only maladaptive behaviors. You were talking about aggressive behavior, severe, self-injury, all this kind of stuff for, high kids. But the problem with autism is the communication skills, the social skills, and sometimes if they are not well taught, eventually people will become aggressive. How do we prevent that from happening? Is what we do as behavior analysis. So I'm going to finish. Okay? So maladaptive behavior are the result of skills that were not being taught. By who? Because we didn't have experts that could do that. Now we have a bunch of behavior analysts, lead analysts, and actually we have RBTs that did great passing the board exam to implement the behavior assessment plan. APD, you don't have to be an RBT to work as a behavior assistant. So we need to adjust the thing and get them right. Thank you.
So we have about 2 to 3 minutes, and I know we have several, about 2 or 3 more speakers. If you are interested, we can extend the time by another 10 to 15 minutes okay, Mr. Snow is waiving his time. So we have Suzanne Sewell and Diane Donahue. Is there anyone else who would like to speak? We have one more person. I do need to find out, we are willing to extend the time by, I think, 10 minutes, if everyone is agreeable. Okay, so we will have a hard stop at 11:42. Okay.
Thank you. I'm Suzanne Sewell, the Florida Association of Rehabilitation Facilities. We represent provider agencies across the state of Florida. Many of them provide behavior services. So I want to offer some comments I received that came from the South Florida area, primarily Broward and Dade County. Many members, I think, will be attending follow-up sessions. First comment was that the agency has a 5-page handbook for providers that only includes general guidelines. I've listed out some of those, like establishing medical necessity, enrollment, credentialing, treatment models, and more that needs to be addressed. So those are provided for your consideration. These providers are asking for more timely notice and opportunity for input or planning before the agency implements policy and practice changes. So thank you for what you're doing today. I think when there was a transition from Beacon to EQ, several providers went 8 weeks without payment. That's very difficult for anybody to operate. So I would ask that you keep that in mind. The agency contracts with companies to manage an authorization process. Here that in South Florida, the companies and vendors are not staffed to handle the volume of submissions, nor are they trained well enough to evaluate and provide reasonable feedback or assessments or treatments. So reporting that is something you may want to consider. Asking for more responsiveness to consumer concerns rather than, you can find another provider if you don't like the service. I think there was some consideration there that there were inherent problems in the way the service is being done that may be beyond the control of the provider. There were some concerns with fraud. Hopefully we're beyond that, and it is very good that you're lifting the moratorium for South Florida, so thank you for that. Discussions about the RBT and some changes there. There's some concerns. I think we discussed the indirect cost and the supervisory cost and how those are included in the rate. So if people would just keep that in mind and look at that closely. And had several comments and concerns about the pending request status. There seems to be a perception that maybe all requests are being pending. Mm-hmm. And I don't know, I cannot tell you specifically that's happening, but I've heard that probably at least 5 or 6 times. So however pending is being handled and what we can do to expedite that process, I would ask that you look at that as well. Thank you.
Thank you, Ms. Stewart. We'll look at the document that you provided and look at the requests that are in a pen status. I can tell you that we do believe that the MDT approach will address the complaints and concerns that we've heard from the providers around pending cases for additional documentation and not really having all of the information that the provider believes that EQ Health needs. So, okay. All right, so the last, I think we have a couple people in the audience, but Diane Donahue indicated.
My name's Diane Donahue, and I have a 17-year-old son, Ian, who has autism.
Can't hear you.
Is that better? I'm an autism mom. I have a 17-year-old son who has autism, who's in the system. So when he was diagnosed at 2, we had no coverage. ABA wasn't even a thing. We mortgaged our house, $150,000, just paid it off. My husband's insurance opts out. So we waited 10 years on the list to get Medicaid. We got it. We get text. They're making $15 an hour, $14.50. They leave us when the insurance case comes because it pays more. I get a text, they leave. I get a text, they leave. We went through 9 texts one year. Then the rates changed, and I got master's level texts, and my son's world has changed. He was hospitalized for sepsis. He elopes. We found him in streets. I mean, and now what? You know, I'm concerned. I'm concerned as a parent. You know, he's my baby. I want quality. I don't just want a body. So before, it was a job. When you make $13 an hour, it's a job. My 16-year-old makes $15 selling french fries at a water park. What does that work? When you're making a real wage, when you have a real degree, when you commit, it's a career, and you invest. Mm-hmm. And my son is out in the community. He's employed. He's learning to drive. Watch yourself. He's happy. My brother had the same diagnosis. He died last September. He died of septic shock because his SIV and his self-care was so poor. And he didn't get treatment. So I'm fighting for my kid's life. It's very important. So think about these things. It's not just dollars and cents, it's kids. And you might think of a few bucks, but at that rate, I'm terrified of what's going to go. I'm terrified. I don't want the guy off the street in flip-flops who took a 40-hour course because it sounded better than Walmart. I want somebody who went to school, who understands autism. My son, if you're going to work with my kid, you have to be PCM trained. That's $1,200 right there. He will take you down. Who wants to do that for $14 an hour? He's 6'3", guys.
have 4 minutes left. How many more speakers do we? We have 2 more. Okay, gentleman in the pink shirt, and then right behind him.
There's not an explanation of how the team thing is going to work. Are you going to post that on the site, how the team thing is going to work with each
additional trainings on that. There'll be additional trainings on the MDT process. So you'll have an in-depth overview of how that's
Am I
going to
coming in
work
clear?
and operate.
Yeah. My name is Pearson Klein. I am a BCBA owner of Behavior Modification Solutions in Tampa, Florida. All representatives of AHCA and EQ, thank you for your time today and listening to us. I'm just going to speak from the heart here, because we can discuss numbers, we can discuss data, but the heart is really where it counts, at least as far as I'm concerned. And I couldn't talk until I was 5. And now I'm a BCBA, providing services to kids who I can only hope have the same opportunities as me now. That's why I do this day in and day out. It's not just a job. This is personal. And for anybody who runs a business in ABA, the RBTs are the center of what we do. We as BCBA cannot do our job without them doing theirs. Period. Do we make the plans? Yes. Do we supervise them? Absolutely. But it's those guys that are going into the homes, doing the work, collecting the data, taking the hits and the swats and the pinches and the bites. Being the eyes and ears that we do not get to use every day with those kids. They deserve to be treated with better respect than what you guys are offering them now with those rates. It's a board certified position. You wanted them to become board certified because the BA status wasn't good enough. And now you're going to reward them with that? When it costs $100 since they're applying for the exam? One can argue about what BCBAs and BCABAs are making. You want to take money away out of my personal pocket? Fine. But don't do that to my workers. They're the backbone of my company, and I guarantee you at these rates, I'm going to have to refer out my 13 clients.
Yep.
Hello everyone, my name is Alvin Suarez. I'm from Complete Medical Billing. Yes, I'm a biller. I represent various agencies in Miami-Dade County. And I'm going to piggyback on what he said regarding the payment structure. Anybody was able to become an RBT or a behavioral assistant prior to January 1st, 2019. Anybody was able to do it, and the payments went up from $12 an hour to $15 an hour to now where, because of the moratorium, there's RBTs getting paid $30 an hour in Miami-Dade County in order to provide services to these kids. So let's say we weeded out the bad ones, okay? Let's say they're now board certified. They have a board certified status, but now the BACB is also telling the agencies that they have to pay them on the salary. So now you have to take into consideration 941s, withholding, FICA, Medicare. Okay, those are things that nobody was taking into consideration before. Before it was an hourly wage, again, $15, $16. Add that, if you have more than 50 employees, you now have to offer them health care. So now they're not going to get paid. If you guys are offering $20 an hour, basically around there, they're going to be back down to $12 an hour after everything, because agencies themselves there has to be some profit. As minimal as it is, there has to be some sort of profit. So please, please, please reconsider those RBT rates. I don't think that you guys went through the numbers. You guys went to Indeed or ZipRecruiter. That doesn't work. That does not work. I think you guys really need to refocus those and look at those numbers again. Thank you.
Okay, thank you all for your time today. I think we received a lot of great feedback that we will take into consideration as we move through this process. This is the first of many, many, many meetings to come. So I look forward to seeing some of you, I'm sure, in other parts of the state. I would ask, as you guys are exiting, we're asking you to exit this side of the room. There's an exit right to my left. So if you would not mind exiting through those doors. Thank you again. Safe travels back to your destination.